Thank you very much, everybody, for joining us today for this webinar titled Utilizing Extracellular Matrix to Reduce Infections in Cardiac Implantable Cardiac Devices. Today, I'm going to be joined by my good friend, Brian Olshansky. I'm Randy Lieberman, Professor of Medicine at Wayne State University, and Dr. Olshansky, Brian, close friend and colleague of mine, is Emeritus Professor at the University of Iowa. We're both electrophysiologists. My faculty disclosures for today is I'm consultant for Azeo Biologics. Dr. Olshansky?
No relationships to disclose.
Very good. Okay. This program is being provided by HMP Education, an HMP global company. It's supported by an educational grant from Azeo Biologics. Our learning objectives today are consider implant techniques to reduce the risk of infections, describe biological extracellular matrices as their value, and to elucidate how an extracellular matrix can create and maintain a healthy cardiac implantable electronic device pocket to reduce adverse outcomes. So Brian, I thought what we would do is have you start off with some of the historical points that have led to some of the breakthroughs and guideline applications and treatments of surgical infection sites.
Well, thanks, Randy. You know, there have been a lot of milestones over the years about antiseptic and aseptic discoveries, even before anyone even knew what a bacteria was. Going back to Hippocrates, he used to clean wounds with vinegar, and microbes were only described later. And what was really interesting was what Semmelweis did. Semmelweis realized that the women that gave birth in hospitals were way greater risk for developing sepsis and death, actually, than if they gave birth at home. He realized that hand washing was important, and that really upset the doctors that he worked with. So they thought he was out of his mind. They put him in a mental institution, and actually he was beaten in a mental institution, and in that mental institution developed gangrene and it got an infection and died, ironically enough, from an infection. So as time went on, we began to learn a little bit more and more about the importance of keeping wounds clean and about the risks of infection and ways to sterilize equipment and even using antibiotics. So this has been developed over the years. Now we have an issue of an implantable device in patients that can lead to the risk for infection and erosion that can lead to ultimately an infection from that point on. So I think we've made tremendous leaps, but there is a lot more to be done going into the future to look at ways that we can prevent the risk of bad outcomes in patients that receive implantable electronic devices.
So I think what we can summarize is that these breakthroughs inspired hope for surgery and better wound healing. And what we're going to do is look at tonight how far we've come along or the directions that we can even go further. Now, we've included for the audience, Brian, a list of different guidelines here. And I pay attention to the one on the bottom that was just recently reviewed in JAMA, January of this year, where once again, they reviewed surgical site prevention and techniques that we should be using. Now, the reason I've listed these, Brian, not to surprise you, but what I've done is put together a few scenarios here. And what I would ask you to do as we go through these case presentations, instead of reciting the guidelines, what I want you to do is sort of tell us your practice habits and then tell us what the guidelines might say or do. So here we go, Brian. I welcome your input. First, what I'd like for you to see is that here's a surgical site that we're looking at. And what we have is that we're getting ready to start a procedure in between cases. So Brian, we have different colors on the screen. Which of these are critically important? And do they really do critical cleaning during the procedures that you see?
Well, you know, actually, Randy, I've never seen critical cleaning being done in the lab. I know, you know, every once in a while, someone comes through and says you need to have certain, you know, exchanges of air and a variety of different things about keeping, you know, the place clean. But in fact, rarely does anyone clean most of the equipment that's in the lab. So I'd say, even though, of course, it would be perhaps best to make sure that there is few in the way of bacteria circulating around. In fact, that really doesn't happen too often, I don't think, in the actual electrophysiology lab or in the operating room for that matter.
Right. In this video that we see, this cleaning in between cases, I agree. I've never seen it, but yet I think our guidelines would say that we're supposed to be doing these critical things.
Absolutely.
So let's turn to something that we might control a little bit more. And again, I want you to think about your own practice and then look at as to what the guidelines might say here. Should the patient cleanse before you do the procedure? The night before? Do you delay the case if the patient hasn't taken the bath the night before? What type of soap do you recommend? Should they use a brush? You don't know, you don't care, and you just schedule the patient for the procedure.
Well, I mean, yeah, I guess I do care. Whether I know is another question. I mean, it varies. And sometimes you have a patient that comes in emergently, needs a pacemaker right now. They've got complete heart block and a heart rate of 20. You're not going to, spend, a couple hours scrubbing and, trying to keep everything as clean. You got to put the pacemaker in, if that's what the case may be. But for the most part, you'd like to have as clean an environment as possible, in my opinion. I mean, I think, some cleansing makes some sense. Cleansing the day before is what we kind of recommend, but I'm not so convinced that it makes all that much difference. I mean, it's hard to do a randomized trial of this. I mean, there are data out there, and we do use chlorhexidine in our lab, but I'm not really convinced it makes a big difference whatsoever.
So, Brian, I've put the recommendations up here. And these come from the World Health Organization. I don't know if you want to review that for the audience or just summarize it, what's on the screen there.
Sure. I mean, there are a variety of different studies. All the studies have some degree of problems with them. Some of them are small, some of them are large. This is a comparison seen here of chlorhexidine versus soap. And when you look at the meta-analysis of the data, I mean, there may be a little bit of a trend, but in actuality, even with these data, that really makes very little in the way of difference. And so I agree that it's an unresolved issue. This is really, it doesn't make all that much difference. And a lot of this is voodoo, where we recommend doing one thing, but the data, the evidence is really kind of suspect, I'd say.
Okay, I'm sure the World Health Organization is happy with us on that one. So with that in mind, let's turn to something maybe a little more concrete. And here you give us a little more of your opinion on some of our guideline recommendations. So I present you with a case, a 67-year-old with diabetes and hypertension, scheduled for a prophylactic implantable cardiac defibrillators. I won't ask you if you ordered him to bathe ahead of time. I'll go into something maybe a little more concrete. Do you screen him as a staph carrier? Would you delay the surgery until you get the results back? Or you decolonize all your patients or just high-risk patients? And maybe you could give us your clairvoyancy on what is a high-risk patient.
Randy, these are all really important questions. And, it varies so much from place to place that I work. And I think the reason for that is each individual place has their own kind of thought about what the best options are. And there are some data out there that, that it's possible that decolonization will make a difference for, specific patients. And a patient with diabetes perhaps is at higher risk. So I think there are some recommendations that go in this regard. And I don't think it's unreasonable to do this, but to make a tacit statement, you have to do this for all patients, I'm not completely sure. And who the highest risk patients are, really vary. I mean, I think diabetes does add additional risk. But, so yes, in some places we do it, in some places we don't. I don't know that it's a blanket statement that everybody needs to be screened, at least not in my practice.
Okay, and if you want, you can summarize. Once again, I've put the data from the World Health Organization and then the various other guideline references up there for us.
Right. And I mean, it varies from place to place, from recommendation to recommendation, but many think it's reasonable. And I do think it's reasonable. I don't think it's mandatory to screen for this. And then to consider, antibiotic ointment is not unreasonable to do this. It certainly wouldn't harm anything. I mean, I guess you could have some kind of reaction to the medication, but I think it's reasonable to do that.
Okay, so I'm glad that we're moving right along here with straightforward, clear answers for our audience. So let's go. I'll give you a simpler one. Do you recommend hair clipping, shaving, nothing? I think this is a little easier. But then I'll give you maybe just a little bit of a curveball. Now that you're ready to prep the patient, how do you tell them to do the skin prep for your patient? Alcohol, chlorhexidine plus alcohol, maybe iodine, like when you and I went our training days. I'll let you go ahead here, Brian.
Yeah, I mean, again, everyone has their own point of view here. I don't think there's anything you could say absolutely. I mean, I think shaving actually creates more of a problem because I think it, it irritates the skin. It's going to cut the hair. There's possibility of infection. Doing nothing or clipping may be a little bit better. When it comes to skin prep, I can just say, back, and I go way back in this, going back to the Bellevue days, before there was even povidone, we used iodine, plain old iodine.
Yeah.
And then we would just swab on the iodine and then we'd swab on the alcohol. Now that no one does anymore because of the relationship. I mean, I still do it once in a while, even though it's forbidden to do that. I mean, chlorhexidine is the way to go. This is what people do, chlorhexidine and alcohol. I mean, for example, for me, I can't use chlorhexidine. It totally ruins my hands. But, and there are some reactions, but that's what's recommended as the better way of going, chlorhexidine with alcohol.
Right. And I think the panel, this one has a little bit stronger opinion now, where they recommend that we really go to alcohol-based antiseptic solutions on chlorhexidine, moving away from the iodine or povidone, as you said. And then again, really minimizing, as you said, shaving, where we debride the skin and may create more risk for infections.
Yeah.
Okay, you've already gone on to this one here, Brian. You and I have discussed this many a times. Okay, so time to do your hand washing. Is it okay just to do the old calf lab one? We just run our hands under the water and we call that a scrub. Do you actually do a 6-minute surgical scrub? Or can we go to the so-called dry wash or Avogards that most of us have sitting around? And what do you really tell your fellows in this day and age as an emeritus professor, respected in the field?
Well, generally, I recommend not spitting on your hands and then rubbing them together. I think that's probably not the way to go. However,
Okay.
and I think, a wash is a good idea. I can't use chlorhexidine. I mean, this stuff just totally destroys my hands. There are those who, think that Avogard is a really good approach and that you could do a dry wash. And especially in between cases, it works reasonably well. And, I think this is one approach. And otherwise, it's going to be, a chlorhexidine scrub or with alcohol.
Yeah, I think that's the key, is that what Brian brought up, that when you use the Avogard or the so-called a dry wash, it's still recommended that your first scrub should be a regular wet scrub. And then the in-between, you can go to the Avogard. And for those of you joining us for this webinar, I highly recommend that you go to the website, because you have to learn how to use Avogard. Okay, you can't go into the room and then go take a towel and dry off the Avogard. Okay, it doesn't work that way. You have to sit there, let it air dry. There's a couple of techniques for doing this, and I recommend it. And we've included on each of these slides, as you've seen, the guideline recommendations for you with the references. Okay, so we're moving along here, Brian. In your day, in my day, sutures, I don't think anybody discussed it with us. I think we went into the room, we tried to remember what we saw some surgeon use, and we used it. Nowadays, technology has advanced just like everything else. Okay, so let's limit this to 2 questions, Brian. Do we use antibiotic-coated sutures or not? And the second question is, should we start to look at using this knotless sutures or barbed sutures for closing so that our knots aren't dehiscing?
Interesting concepts. I'm sure it costs a lot of money. I've never used any of these things. And I'm not sure that the data are all that compelling, but I'm sure that if there are data, it comes from companies that want to sell the product. But I have not seen that there's any real benefit in doing this. I mean, I certainly don't use them in my practice.
Okay, so the guidelines recommend the use of these antibiotic coated sutures. Okay, so they seem to think that there is moderate quality. As you know, they usually say strong, moderate, or weak on it. Okay, and again, each of the societies have had a little bit different strength of recommendation on this. But I think these antibiotic coated sutures are going to start to be more prominent in our practices, and many places are using them. The barb sutures or the knotless sutures, as you said, are interesting technology, interesting concepts. There's no recommendations yet on those. All right, now, Brian, I've saved these next 3 slides for you, and I'll let you sort of control going through them as you want. But let me introduce the subject, okay? Because I know this is one you and I have a lot of opinion on. We're going to start first with wound closure, and then we're going to move in to antibiotics. So the first slide here, I just want you to tell me, do you use staples or do you use Dermabond? And the second question is, do we need to use any special material on top of our wounds after we close them? And then my final question, before I give you the antibiotic question, is when do you get your patient bathed?
Well, these are all great questions. I mean, most of the time, I don't use staples at all. I have no, I mean, maybe one time, but almost never. In terms of glue, occasionally I use glue, but I try to stay away from it. I don't particularly like using glue. And if I do use glue, which is rare, I would let someone get the area wet without scrubbing in about 2 or 3 days. But for the most part, what I use is just plain old sutures and steri strips. And basically keep the area completely clean and dry, exposed to the air for at least 7 days before allowing a patient to bathe.
Okay, wow, you're finishing out on some strong notes here. As you can see on this slide, Brian, there's no difference in tissue adhesives versus staples. So obviously there's not going to be a strong statement. I think it comes down to what you're most comfortable using, and tissue adhesives versus sutures. So I think it comes down to practice patterns there. Furthermore, when we take a look about using any of these silver nitrate dressings, you're absolutely right. The panel suggests not using any type of advanced dressing over a standard dressing on primary closed surgical wounds for the purpose of preventing surgical site infections. Perfect. Now, as I promised you, Brian, these next slides, I turn the control over to you with leading us through. Do we use antibiotics to irrigate the wound before we close? Then do we continue them afterwards? Do we give antibiotics prophylactically before and after?
In the terms of this slide, and I'd like your opinion too, Randy, because basically I irrigate with saline, although I don't know of any good data on it. And actually, I don't know that antibiotics are actually a good idea, because although in some sites that I work, antibiotics are put in the saline against my knowledge, they don't ever ask me the question. I mean, it's a lot like using antibiotics that can lead to all kinds of GI problems. What you're doing is you're killing some of the good bacteria, and the bad bacteria can still be hanging around, because you're never going to get a pocket completely sterile of every single bacteria. And you like to keep the wound reasonably clean, get as much blood out as you can, and any other, dead tissue, but for the most, so that the healing process will take place. But I would never, I don't use iodine, and I do irrigate. Sometimes I forget to, but for the most part, I use, that's what I recommend.
No, 100% right. And I think the panel has really stepped in and all the different guidelines that says we should not be irrigating with antibiotic solutions or any other solution in these wounds. If you're going to irrigate just to get the blood clots or any of the debris out of there, just saline, as you've mentioned. And that's 100% in agreement with the panel. So moving along here, Brian, prophylactic antibiotics ahead of time and or afterwards. And then the next slide after that, you'll comment on the so-called envelopes out there.
Okay. So, we do use prophylactic antibiotics. In fact, we're under the gun with this. In fact, the way things are working at our institutions is you need to give the antibiotic within an hour. It's kind of what the recommendations are. And if you don't follow that, you're kind of going against the recommendations. So we have to do that. Whether it makes a difference, I certainly, I think cefazolin is all I use unless someone's allergic. I don't like the combination of two antibiotics for the most part. Red man syndrome with vancomycin. I mean, the risk of killing other bacteria that may have value. I think it's better to stick with one antibiotic if at all possible, and not just sterilize the entire patient. That doesn't make sense to me.
And can you comment on the padded study, which is up there?
So the padded study here shows different procedures, using conventional and this incremental approach, as you can see, with using vancomycin and cefazolin, looking at pacemaker CRTs and ICDs, and basically showing that there's a wide variation, but no difference between the two, so that there's absolutely no reason that you just want to add an extra antibiotic and be more aggressive, which can actually lead to more problems, I would think, in the long term, in terms of allergies and other issues, than just to stay with a single dose of cefazolin beforehand.
Right, and there was no benefit to continuing the antibiotics post-operatively.
Right, that's
okay.
right.
So I think that was an important thing that came out of the padded study. Now, let's take a look, and I don't want to do a whole lot of thought, but just a little editorial on using the so-called envelope.
Yeah, I mean,
thoughts are here.
These envelopes scare me. This particular one, this polymer that's mixed with antibiotics. Again, it's very much, think about the padded study. What you're doing here is the padded study, on steroids, so to speak. I mean,
Right.
you're keeping this antibiotics, killing all everything in the pocket, and then you end up with this polymer pouch, which can lead to inflammation that can actually cause almost like a really serious scar. And so I think the data are misinterpreted, in terms of the New England Journal paper, as though this is of benefit. I mean, I think if anything, when you look at the data really carefully, it actually shows the risk to harm, especially with bacteremia and, the potential for endocarditis, because you may prevent infection locally, but that doesn't mean you're going to prevent infection throughout the wherever the leads are going. And so I would hardly ever, in fact, I can tell you one case. I had one recently where one of my colleagues actually put one of these things in, and the patient ended up with a lot of pain afterwards and kind of a seroma, and I went in and just had to remove it. So I try to stay away from this thing. I don't think it's valuable at all.
Right, and I think just full open disclosure, I should let everybody know, Brian and I have also written some editorials and letters to the editor on this subject, so you could Google that if you're interested.
Absolutely.
In that area, just so everybody knows. We have a sort of strong opinion on this.
Right.
Okay. Now, Brian, if we stick to these guidelines and we do what we're doing, theoretically, we should have eradicated these things. I mean, we inspired hope from the days as you brought those milestones up. We've added to them. We've looked at antibiotics, and yet we are not seeing, as you're going to show us in these next couple of slides, a decrease in these wound complications. I just put 3 studies up here showing that even at 1 year, we still have a significant risk of infections. I remind our audience that these infections carry up to maybe a 15% mortality rate. Now, Brian was one of the authors with Dr. Joy in an HRS article that looked at why we are not seeing a decrease in wound complications, but we're actually seeing an increase in wound complications. And Brian, go ahead. These next couple of slides I put in here, we welcome your expert opinion and maybe summarizing this sort of paradox to us, where we have better sutures, we got better antibiotics, we got better techniques, better surgical gloves, better airflow, and yet you're going to show us that just the opposite is occurring, that we're having more complications, not less. Is it just because we're doing more procedures, Brian?
No, I don't think that's the case. And actually, so here are the data. And I just want to say that, Dr. Joy was, one of the fellows who worked under me. This is a national database. I was a senior author on this manuscript. And so these are data from the entire United States, essentially. And this is not just one location. This is what's happening everywhere. And so then the question is, when you look at this and the number of devices implanted by single individuals has not risen that much, and yet there's an astounding increase in the risk of device-related infections that have been reported. As you can see here, the total device procedure number is actually, if anything, dropping off, but the device infection rate goes up. I want to point out a couple of things which we have not talked about, and those are some of the real basic issues when it comes to implantation of devices. We have to think about proper gowning and gloving. We have to consider the fact that if you take a long time to do a procedure and you're in the pocket for a long time and you cause a lot of, debris and dead tissue, the risk of problems is going to increase, including erosion and infection. And also the risk of hematomas are a big issue. And that gets to many issues, because one thing I found is that, and maybe you can comment about this, Randy, I use plain old Bovie. I mean, the photon blade, is nice. It cuts through things, but it also can damage tissue to cause bleeding. And especially in patients that are on DOACs, and you start them back up on it in a couple of days later, the risk of hematomas, especially in diabetics and people at higher risk with renal insufficiency, can be a big issue. So I think we have to consider these things as potential insiders. Why don't we take a look at some of the other data here?
So as we go through this data, I want to remind the audience, maybe, and Brian will bring up a little bit on this historical data. Is it just because, Brian, we're doing more complicated procedures, or emphasize to us whether we're doing more complicated procedures on more complicated patients? Because I think this becomes a key concept here as we go through this data here.
Well, I think part of it could be, part of it could be more elderly patients that are sicker that we wouldn't have taken to the lab earlier. But I also think it's got to be related in part to surgical technique. I think that's part of it. And as you can see here, as time has gone on, there hasn't been a major change, I don't think, in the population, for example, between, let's say, 2006 and 2010 or 2011. And yet you can see a change in the risk for even single chamber pacemakers, but also for CRT devices, which the risk is going up further. So again, the more complicated procedures that take a longer time when you're in the pocket and it's open, exposed to the environment for a longer period of time, and the risk of bleeding is greater, I think that you're at greater risk. But I think part of this is technique, and those risks are increasing. So we have to be concerned. And the other issue, I think, is, as we've already been talking about, we're relying on other things like intravenous antibiotics beforehand, about cleaning the skin, about these pouches, these antibiotic pouches, that's going to take care of the problem, when it really comes down to good surgical technique as the real key issue in terms of getting the best benefit in terms of risk of erosion and infection afterwards. Now, when you look at these data here, you can see that patients that are at higher risk include those with end-stage renal disease, patients that have had prior hematomas, and those who have got other inflammatory processes going on. So in some cases it's changed, but in other cases we can see that there are higher risk patients that are going to be the ones that are greatest risk for getting device infections, especially those that are undergoing CRT devices.
Right, and I think that as Brian's pointing out, maybe we're dating ourselves a little here, Brian, but in the days when we were going through our training, we were being taught by the surgeons and sort of the old homestead techniques of surgery. And as we've evolved this out into the EP labs and the CAF labs, I wonder if we've lost some of those details that the surgeons were so rigorous on their dogma, or the mystical mystique of being in the operating room that they foresaw on us.
Yeah, so some of the younger fellows may not follow dogma as much as they follow sloppiness. I don't know if that's the case or not, but
I think you hit it right on the head there, but we'll move on here. And let's go to a case here, just to keep the audience moving along with us. Okay, so I think this is something we all typically see. And this is a patient about 2 weeks ago. He got a replacement of his device. Okay, and he complains of a little itching over the pacemaker site. Maybe that's what the little irritation marks are here. And so, Brian, what do we do here? Is this infection? Should we go ahead and throw more antibiotics? I mean, it's kind of like give them a Z-Pak. I mean, Z-Pak cures every viral sore throat we have, so it should cure this problem. Or just do nothing. What do we do here?
Well,
is it just normal healing?
It's not normal healing. I don't think it's an infection, although I can't rule it out completely. I think that giving antibiotics isn't going to make any real difference. It may actually create harm. It's not what I would like to see, but I'm concerned about it. But at this point, again, with a device replacement, patients are at greater risk for having problems, and this healing process is not exactly what I'd like. But at this point, I'd watch it.
Okay, so I guess what we're saying here is we got a poorly healing wound that we're not ready yet to say it's an infected wound that's healing poorly. Correct?
I agree. Yeah.
All right. So we comes back 10 weeks later.
Well, I assume it's the same patient, but I don't know.
Oh, yeah. Well, yeah, that's 10 weeks later, the same patient. I didn't throw a different patient in here.
But,
I might do that to you, but this is a little bit, we'll keep it kosher.
Yeah. Well, being kosher, this is, concerning. I mean, I don't like this. I mean, I'm not going to open it up. Antibiotics aren't going to necessarily help. This is concern. It's a very concerning situation, and you just need to continue to watch and see. I mean, I assume there's no white count. I assume that there's no fever.
No. That patient just maybe itching, a little tightness of the skin around it, as you can see, contraction. And
Right.
I mean, no surprise. We go out here about 4 or 5 months later, and what do we find?
You got a disaster.
The pocket is opened.
Yeah, I got
a
an erosion.
disaster.
Yeah.
Right. I mean, so I wouldn't be surprised that there's no pus in this pocket. Okay. So we have a poorly healing wound. And what happened here is that there's certain stages and phases of wound healing that should occur. And what I'd like to look at in this next slide is to remind for everybody, what are the risks, Brian? Because you went over this on your slide before, whether you recognize it or not. What are the risks for a surgical site infection patient? A patient is going to be at high risk for a surgical site infection versus a patient who's at high risk for poor wound healing. Okay. So what would off the top of your head, can you separate those two patients, or are they the same patient?
I mean, there's a lot of overlap here. I mean, I think people that have renal insufficiency, patients that have diabetes, patients that are on steroids, older patients are at greater risk. People that are at greater risk for wound healing often, and actually I just had one recently I want to talk to you about, because it was just on Friday. I had a patient that was on steroids. She was coming in for a device replacement. She had a lot of tenderness around the device before I took it out, and it was kind of sticking out. She had lost a lot of weight. She had skin that was very, very thin. I could get 3 layers around it, but it was hard to put them there. And I actually, well, I think we're going to talk about this later, but I won't mention it. But I was very concerned about her. She, especially on the steroids, as a problem with wound healing. But there's a lot of overlap between infections and wound healing.
Right. So I put them up on here, and what I want the audience, because we're going to shift to wound healing versus infections. Now, the CDC defines a surgical site infection as an infection that occurs within 30 days. And sometimes they'll go out to 90 days if there's an implanted device. Okay, so we understand that. That's a primary bacterial infection or fungal infection that occurs immediately surrounding the surgery. Now, the second concept is that we have delayed wound healing. Maybe our edges of our wound don't get epithelialized quicker because maybe we have patients, as you said, older, renal disease, diabetes, poor revascularization, as we're going to look at these. So our wound's not healing quick enough and we're having more inflammation. And then what we can do is have an infected, poorly healing wound, like a decubitus in the back. Okay, so let's take a look at this. And I think this is an important concept, especially as we look at this for the rest of this presentation. So I put here to remind everybody. Yeah.
Let's mention one thing, because about anticoagulation. I think it was on the slide, but we should really keep in mind that anticoagulants can be a real problem with hematomas and problems with healing.
Absolutely. And especially they even lead to more inflammation or more sources. Now, when we take a look at this, just to remind everybody of their medical school days or surgical training days, wound healing goes through, we break it down into 4 stages. Okay, And it's like baking a cake. You can't put the icing on until the cake bakes. It won't work if you just throw the icing in there. Okay, so when we get a tissue injury, whether that's a surgical injury or trauma, we have to get hemostasis. So the platelets arrive there. They want to create hemostasis. But remember our platelets. Our platelets also get activated, and they are great recruiting agents. They're going to secrete chemokines and cytokines that are going to attract our neutrophils into the area. Now, the neutrophils are very important because they're going to attack the free-floating bacteria. And Brian's going to talk a little later tonight, the difference in free-floating bacteria and ones that have already colonized it. And we have in here the neutrophils that attack that. And for the first 24 to 48 hours, it's normal to see a little leakage out of your wound. That's good, because that's the neutrophils and the platelets trying to push the debris out. Now, as the wound starts to recover with granulation tissue, these neutrophils also send out signals, and they're going to call our macrophages in here. And the macrophages are going to be very important conductors in this part, because they're going to also engulf these neutrophils that become apoptic. They die out once they start to engulf the foreign debris, the dead tissue. Okay? And these macrophages also are going to secrete more cytokines. They're going to activate different antimicrobial properties, matrix metalloproteases that we're going to talk about. Now, this is inflammation. Inflammation can be good or bad. If it keeps destroying the tissue, it's bad. Now, the macrophages have to send signals to the fibroblasts to fill in this devolved area of the dead tissue with some collagen. But now the collagen that it puts in there may become a scar. Think of a heart attack when we fill in that dead tissue. That's not very functional. What we want is to go from this proliferation stage, and when we have wound contraction occurring and epithelialization all being mediated, that we have to convert over to remodeling, where we hope we call in some pluripotential cells that can restore the natural tissue or restore better, healthier collagen. Now, one of the key concepts here is going to be the extracellular matrix that you can see on your slide that lies below the epidermal layer. Most of us in our medical school and histology classes just thought of this as a physical structure. But what we're going to see in these next couple of slides is that this is really a symphony hall, this extracellular matrix. And it has lots of musicians down in here. And the coordination of those musicians and the interaction of them will determine whether you get a symphony or you just get noise or destructive noise. Here was just an example to see what we're talking about, where we see this extracellular matrix sending signals to the epidermis to cause proliferation and heal. Healing requires contraction of the wound, and when the epidermis touches those cells, it has to turn off so we don't get hyperplasia. This next slide is a 3D dimension looking at this extracellular matrix. And what you see are different peptides, different proteins that are in here waiting to be activated sequentially to go through the healing stages. We need to get angiogenesis so that we get new highways. Because remember, when those platelets came in there, they clotted off some of our capillaries and some of our blood vessels. Okay, so we need highways for the recruitment of neutrophils and macrophages in and for the exit of it. We need a way for the chemokines and the cytokines to go out and to call it the appropriate things. And I'm going to show you a little cartoon of this as we get ready for a little bit more discussion here. Here we're looking at an extracellular matrix. And inside here, I put antimicrobial peptides. I've put in here different proteins, growth factors. And what we see is that our macrophages have stimulated one of our matrix metalloproteases. He comes in here and he's a protease. So he activates some of these proteins to liberate them to go through the phases of healing, sending out the growth factors, the cytokines, getting rid of the abnormal proteins and some of the collagen so that we can go through the stages of healing. So Brian, Are our macrophages good or bad? And have you heard of the so-called M1 or M2 macrophages shown on this next slide?
Well, this is an area I don't know a lot about, but I would say that, it can either be good or it can be bad. I think that to have this whole symphony ongoing actually can provide, vascularity and proper drainage of any, dead material and actually promote good healing. So I think initially the macrophages are good, but ultimately, it may create more of a problem if it continues on and on. So this can be a part of the inflammatory response that can lead to healing, at least it would seem to me.
Good, because we're going to touch on that in these next couple of slides. Now, what we see here is that we can look at characterization of wound healing, and then we characterize our macrophages. So M1 macrophages are our inflammatory macrophages. And an example of where these could be destructive is think about in something that we deal with every single day. Think of lipids that are subendothelial. Macrophages are recruited in there. And these matrix metalloproteases that are activated via our macrophages can destabilize the plaque and cause plaque rupture. Okay, so once again, good versus bad. Now, part of the healing process is the conversion of these M1 macrophages to M2 pro-remodeling. And one of the key characteristics we see here is that the fibroblasts become myofibroblasts. We see their correct type of collagen, more functional collagen being laid down, or we see the wound and the gland healing in a more stable fashion. And here's an example, as Brian brought up, saying that continued M1 responses can be detrimental. Here's a hypertrophic scar brought about by hyperplasia. So the M1 response was continuing to send those signals out, like I told you, to the epidermis, and we end up with this hypertrophic scar. If we could have moved on to an M2, which it will, most of these patients eventually, and the scar will shrink and absorb down. Keloids are a total different problem, from which it's a genetic predisposition and one that we don't really know how to manage too much. When we take a look, Brian, at this immune microenvironment, what we see on this slide is the characteristics between normal healthy healing and what we see on looking at these ones where we have a chronic wound. And what I'm going to ask you to do is not focus on all of the growth factors and all the individual different cytokines or chemokines, but there's two key differences that we see when we look at these two sub-cartoon pictures. On the left, we see good angiogenesis and vascularity. In the chronic non-healing wound, we see lack of vascularity. We see inflammation is continuing, and most importantly, is we see something called a biofilm. So what I want to do in these next couple of slides is focus on biofilm. I'll focus on inflammation. So can you tell us what a biofilm is, Brian, and how these may be important for us as we look at wound healing? Once again, we're going to look at the biofilm, and I'll go over inflammation in the next slide.
Well, biofilms can form in pockets, and what they are is really how a bacteria kind of protects itself and forms this kind of slimy material around that is the film around the bacteria that are present, presumably in the wound, for example.
Okay, so now the unique thing about a biofilm is it's protected. Antibiotics cannot penetrate these biofilms versus free-floating bacteria, which is very susceptible to bacteria and also our immune response. The biofilms are also strangers and promote inflammation. So what we can say is this: when we implant a device, that device is foreign. The tissue that we've destroyed is a damp, okay? And what we have is also the biofilms or bacteria there that are PAMPs. and the body's going to have an inflammatory response to it. That inflammatory response, unless we can go through the phases of healing, can destroy more tissue, which then creates more inflammation. More inflammation, less vascularity, less healthy tissue, more contraction of the wound, which I think you've brought up already, and less healing. And so this is what we talk about, the poorly healing wound, susceptible otherwise to bacteria, or susceptible as we start to look at device changeouts. So Brian, let's think about a device changeout here. Is it good to have a scar? Is it bad to have a scar? And how would that affect biofilm and the reaction when we go to do the changeout?
Well, I think an avascular scar actually probably can promote biofilms. I mean, I would think that you want to have reasonable vascularity and have the proper inflammatory response to clear the pocket of any remaining serious amounts of bacteria that have deposited themselves there. So you need to have a pocket that's not going to pop open, but on the other hand, you want to have some good vascularity and have all the symphony of issues that will help the healing process.
Okay, and even more so, these biofilms can be sitting here, and when you go to do the device change out, you can disrupt them. Okay, and this may be the reason why we see a device change out 2 times, 3 times the risk of infections, yet a simpler process as we look at it. Or if you have a capsule, a heavy capsule that's been sitting there from previously, and then when you do your surgical procedure where normally these would be free-floating bacteria, they love to get onto the capsule. And then they start to form these biofilm formations, and they can break free and cause infections. So what I'm going to walk you through is just a little case here, Brian, and go ahead and tell us a little bit about this little study that was done and these biofilms and risk of infections.
Well, this basically showed that, in patients that did not have any signs of infection that come for device change out, that some of them have positive cultures. And in those who developed infection, basically had the same bacteria that was found at the time. So there can be colonization that's present and probably present in a very stable way in a biofilm. And then when you disrupt everything with the device change out, you can ultimately develop an infection. So you have to find a way to, eliminate, these bacteria, presumably with a better.
Okay. So this is classic. Here's the patient, sort of like you described, very thinning over his device. We can think that this patient has a capsule. He's sitting there with chronic inflammation, poor vascularity. So he's not going to get good collagen, good skin, good healing here. And when we go in to take a look at these patients' wounds, we see these thick capsules on them. And of course, the risk for complications. So Brian, first off, we'd like to prevent this, which is what we're going to talk about in the last few slides. But should we remove these capsules?
It's a great question. I don't know a great answer. The problem is, you want to get some vascularity. You want to get good healing. If you disrupt the pocket too much, though, it may cause bleeding and not enough healing. There's got to be a better way of doing this, especially when you have a very thin pocket. Because I think just, cutting out all the scar, whether that's going to help or not, you're going to have a thinner pocket, and there's a greater risk for erosion too.
Right. So the key that what we want to see is how can we promote better healing? So the key to what we want to do is we want a way that you and I can help engineer regenerative healing. So what we want to do, is there something that you and I can do at the time of a surgical procedure to provide some key component that will promote the natural healing steps? And this has been looked at in lots of different ways. Cell therapy, where we take cells out of the patient, put it back in to help healing, maybe trying to find the perfect growth factor to spray in there, maybe putting them on a scaffold, some of these growth factors, and seeing if they can promote healing. Now, as we take a look at this, this has led to a commercialization of wonder products out there. Okay, you can walk into any grocery store or any CVS or any drugstore, and you can find advanced collagen properties out there. and all sorts of commercialization. But let's now take a look at very quickly here what is available for you and I and whether we have some data to support it. So instead of trying to find which one of the growth products, cytokines, antimicrobial properties to provide to the patient, why don't we give them all? I mean, that would be the logical thing because you and I can't guess which of the phases of wound healing is stalled. So let's give all these different components back to them. And therefore, the body somehow will liberate them in a synchrony way to get healing. And here we see the epithelium, we see our extracellular matrix, and we see all these different components listed here. Let's not guess which one to take out of it, but let's give them all back. Now, how do we give them back? Well, the ideal way would be to have, for a device, a pocket envelope made out of a biological scaffold that has all these different components in it. Okay, that way we don't have to spray it. This way we could put it in there. And the theory would be if we could find the source for these, is that then the body would see this foreign envelope, and then it would have its own macrophages or neutrophils that say, hey, this is not appropriate. And as it starts to degrade it, it would liberate all of these key cytokines, antimicrobial properties, and metallo properties to liberate in this exact order the phases of wound healing that we're looking for. And so briefly here, Brian, what I've shown is some of the properties that this could lead to. There's actually data that if you could do this, that you can actually reduce infections. Okay, here we see by having provided all these appropriate peptides, growth factors, we actually can reduce the risk of infections and promote better healing. And what I'd like you to do, Brian, is just review in these next 2 or 3 slides, different sources that are listed, and then also the process by how these would be gathered.
Yeah, I mean, I think what you're saying, Randy, is very compelling information. I think what an extracellular matrix can do is help healing by a variety of different mechanisms that are complex, and maybe we don't even understand which one is the key at the time. They're probably working together as a symphony, as you mentioned, and they can help in the whole healing process when you're dealing with the risk for an infection in every single patient with something that could very well help all of our patients. I guess the question, therefore, because there are data now in a variety of different situations, as you're showing here, which patient really is going to be the one, which implant is going to be the one that's going to benefit the most from something like this, this extracellular matrix. And I can tell you from my own experience, there are probably a lot of patients who could benefit.
Okay, so I want the audience to remember, we're not only going to promote this as a super antibiotic product. What we're talking about is that we're going to get better healing so that we don't have delayed healing that becomes at risk of becoming infected. Okay, I think we've reached a point, like Brian has brought up, where if we have good surgical technique, our problem is the healing technique, not the primary infection risk. Okay, so these are different sources of extracellular matrix material that we can gather, but we got to get them decellularized. Otherwise, the body is really going to react if I put a porcine small intestine extracellular matrix in there. And the reason that we use the small intestine is we know we have rapid turnover there in our small intestine, so it has a large number of these products available to us. And what we can do is therefore make a scaffold out of these. So we decellularize them, which we're going to see in the next slide. So here we see examples of a small intestine submucosal extracellular matrix made from the porcine intestine. But we've removed any cellular characteristics that would ever identify this as coming from the porcine, coming from a pig. This just contains all those key components. And you can see that we've made them into an envelope here. so that they could fit around a device. It could just be a sheet, which has been used also. But because we're talking about devices, you would put this around the device. Here's the process, kind of how this would happen. You would go harvest small intestine mucosa, then it's processed by rinsing out anything that would identify anything from the cellular etiology from it. You could never identify where this came from. Then it could be just made into a sheet if you wanted to use it in the abdomen or use it on hearts or different areas in the body where it's been used. Or it can be shaped into an envelope, which makes it easier for us to use at the time of the device. Now, the next slide, Brian, in your own words, I don't know if you've seen this or not. Here we see the device placed into this envelope. And what's happened here is the macrophages and the neutrophils have degraded it. And this is what we're left with. Do you see a large scar here? Do you see good vascularization and angiogenesis here?
I see good vascularization, angiogenesis, and this is exactly why, like I mentioned last week, I used one of these in a patient that was on steroids and has very thin skin and had some tenderness because they had such a thin pocket. So I think this has a tremendous role and has a lot of value. And I guess the question is, who actually should get one, or should everyone get one? And that I don't know that we have an answer.
Okay, so obviously what we've said is that once remodeling is finished, instead of a synthetic material there, it's gone because it's been degraded. Okay, and we get good vascularization. Once again, what we said is that we're going to get these pockets that don't have thick scars. So because this is thin, this is not a site that's going to be as at risk for biofilm formation or chronic inflammation. This is normal healing. Okay, this is not going to create chronic inflammation and poor wound healing. And so as we get here now, what I think is this. What we want to do is put a decellularized extracellular matrix into patients to promote the M1 conversion to M2 healing. Our goal is to have better healing, not have delayed healing, and not put our patients at risk. And Brian, the last question for you is, do we just say, put it into all the patients who we identify as having surgical site wound risk? Do we put them into patients that we think are just at risk of infections? Or do we say, put them into everybody? Because if we can prevent that initial scar, that initial biofilm formation from forming, that's the key to get rid of that high risk patient at device changeout. Comments here as we finish up.
Yeah, I mean, you make extraordinarily important points, Randy. And I think the issue is we don't absolutely know, and I think we need more data. But, at least in my opinion, I think that those who are at highest risk are those that we should consider this seriously. Certainly, any patient that has a device implanted, you want to have the best healing that's possible. But there are those who have the greatest risk, and those are the older people that are obese, that have diabetes, those people that have renal insufficiency, that are going to be anticoagulated, that have very thin skin, that have other multiple comorbidities. That's a good place to start. But in reality, you can make a case that there's no harm in doing this. As far as I know, there's no harm, and there's only potential benefit. It's easy to do. And so, I think we need more data, but that would be my opinion from at this point. But we have it right now.
That's why I put up here, who should receive an ounce of prevention. This is an ounce or two in weight, which may have tremendous downstream when you think of these SIDS infections carrying a 15% mortality risk. And as you've shown, that we're seeing an increase in wound complications. And as I've pointed out, a lot of these wound complications aren't necessarily primary infections, but they're poorly healing wounds that become infected because the wound doesn't heal. And what I'll do is I'll put a conclusion up here, Brian. I'll read my conclusions and then I'll let you read yours, or I'll go over them. So what I've concluded is this, that SIDS non-healing wounds are a common problem, and it's mediated by inflammation and biofilms. That I think adjuvant wound management, constructive healing, biofilm therapy can be provided by extracellular matrix peptides. They're there. We just have to figure out how to get them in there so that the body can use them. And as you've pointed out throughout this, clinical trials are needed to prove this. But I think Brian brought up some of the most important messages that I want people to leave. While this is novel, the ones that I've listed for Brian, and Brian, you can comment on them, is really the core for the key for all of us to remember.
Yeah, I mean, we're just saying, Randy, they're excellent points. And I think we have to go back also to the beginning, and that is that we have good therapies to reduce wound complications. First of all, we have to have good surgical skill and try to maintain no hematomas and everything else we had discussed. But more antibiotics by themselves are not the solution. In fact, it may be creating harm, especially because we may think that may be the solution when in fact it isn't the solution at all. So adhering to guidelines is certainly a reasonable thing to do. Of course, as you've seen from the guidelines, the benefit of any specific thing, whether it be antibiotic-coated sutures or the way that you prep, all these things are important, but they're also not necessarily going to make the major difference. Well, it's also important to consider screening for staph from nasal carriers. These are all important things to do. I think we need to look beyond all of these things because we've had these guidelines now for quite some time, and what we've seen with these guidelines at the same time is an increase in risk of infections and erosions that we need to find the proper solution. And I think the extracellular matrix may be exactly that.
So I want to close as Brian and support everything Brian said. I want to thank him. He's a very close friend, one of my closest friends I have out there. I respect his opinion greatly. He's an expert in a lot of these areas. I think important is to remember what Brian has said, is that if you have a poorly healing wound, antibiotics aren't going to make it heal any better. The problem is the techniques to get better wound healing. I want to thank the support for tonight's webinar, and I hope you found this information helpful in your practice out there. And I hope you'll give strong consideration to using these decellularized extracellular matrices in your clinical practice. Thank you very much. Thank you, Brian. Thank you, everybody, for joining us.